Kevin, over to you.
Jill, thank you very much. My name is Kevin Plunkett. I am the chair of the Phelps Community Board. And on behalf of the board, I want to welcome everyone to tonight's webinar. This is the next installment of our new Insider series that showcases exciting developments underway here at Phelps. We are making significant investments that will allow our exceptional caregiving team to do more for the patients we serve right here at Phelps Hospital. Tonight is focused on our Center for Advanced Procedures, which will house our Neurosciences Center for Excellence. You will hear in a few minutes about how this is a game changer for our community and for all those we serve. This is just one of the exciting projects underway at Phelps. This brief film will give you some of the highlights. Please take a look as Phelps leaders look forward.
Phelps has always been a community hospital that really does big things. When I think about what makes me proud to be at Phelps, hands down, it's the staff. It's the whole team. Whether they're providing direct care or indirect patient care, they do it every day with kindness. Their resiliency shows through. They really are a remarkable group of people.
It's almost like family, and I think that we've been able to really build and retain a small community hospital culture. That culture then trickles down to the patient, so I think the patient experiences that also. So I'm very proud of the staff for what they do every day. The experience of the nursing staff during COVID was certainly one that no one had ever had any experience with in the past. At one point in time, every patient in the hospital was COVID positive. Early on in the pandemic, we submitted a document to the American Nurses Credentialing Center. That organization deems hospitals magnet hospitals, and magnet status it's really the epitome of nursing excellence. We were deemed to be a magnet hospital, our initial designation, in October of 2020. We had a very generous donor who created an endowed scholarship for nursing, and it really is something that will help us to support our staff and to fill our nursing positions. So I think that was really another highlight of last year.
We work together as an incredible team, and I think that's a good foundation for the hospital to have. I think, again, that's the best way to offer the latest, the best, and the safest care to our patients. It's coordinated care. We work together, the whole team. We're very proud of our residency programs here at the hospital. We've had our family medicine residency program here for more than 10 years. We bring in bright, wonderful, engaged, knowledgeable residents. As of this year, we actually now have added surgical residents, and we right now have 4 surgical residents rotating through our surgical program, and it's been incredibly successful. It makes the facility of the hospital more academic, there's more learning going on, it raises the bar. It's wonderful. It really raises the level of the hospital. When we plan our strategy on how to either grow our services or add new services, we know that part of that strategy is not only bringing in the right person, the right providers, but bringing in the right technology so the physician has the tools and equipment they need to offer, the most advanced technology, the safest and best care to our community, our patients.
We have 4 major projects going on right now at the hospital, large construction projects that represent years and years of planning. So right now we're focusing on 3 major clinical strategies. One is neuroscience, another is cancer, and lastly we have surgical services. Another project that we have is what we're calling right now the Center for Advanced Procedures, which is an interventional radiology suite that will focus on really advanced neuro-interventional care. We're building neurosciences at Phelps. We are an advanced stroke center. In fact, we're working towards becoming a Joint Commission thrombectomy-capable center, which is only the 2nd in Westchester County. We will be a Joint Commission thrombectomy-capable center within the next year, and that will be probably the biggest clinical advancement that Phelps has seen in its history. People used to want to go to the city in order to get advanced care, tertiary care, And now they don't have to do that anymore. They could stay close to home and get advanced care right here in Sleepy Hollow. The complexity of care I expect to just continue to increase. One of our clinical pillars and focus areas is mother-baby and maternal-child health. And we've invested an incredible amount into rebuilding our entire inpatient maternal-child health program. Right now, one of the construction projects we're working on is the mother-baby unit. Phelps will be a premium place to deliver your child. We're very excited because it's so unique, it's so beautiful. There's nowhere else you could have a baby while looking over the beautiful Hudson River. So in some ways, the construction projects represent the end of the planning of our strategy and the beginning of the future.
I think we're very blessed to have a community and donors that are so interested and engaged and generous to the hospital and to the staff. You know, during the last 18 months, during the pandemic and afterwards, it really highlighted that support. It's hard to express the gratitude you have for everybody involved in this endeavor. And on behalf of the hospital, I can't say how grateful I am and how proud I am to work at Phelps.
Good evening. I'm Tracy Firetag. I'm the Deputy Executive Director at Phelps Hospital. I'm especially excited about tonight's presentation because it represents one of the most significant clinical advances for Phelps Hospital in our history, the Center for Advanced Procedures. In a few moments, you'll hear from our expert physician panel about the center, but before they impress you with a few clinical case scenarios, I want to tell you how we got to where we are today. When I first came to Phelps in 2018, my role was centered around the implementation of the strategic plan at Phelps. And I remember a day in particular in September of 2018. I was walking through the lobby and I ran into a group of physicians. They were walking out of the physical therapy gym. It was Dr. Emil Nigro, Dr. Rafael Ortiz, who's a neurointerventionalist that I worked with previously at Lenox Hill Hospital, Dr. Toby Bank, and Dr. Barry Geller, who's here with us tonight on the panel. I could tell they were all extremely energized. And when I asked them why, they said, well, we think that this is the location of the next center of excellence for complex neurosurgery and neuroendovascular care for Northwell. They had a sparkle in their eyes, and that sparkle transferred to me. And over the next few months, I started digging in to understand what it would actually take to support a program like this. Then we started building, not a physical structure like we're doing now, but the building blocks that are prerequisites of a new clinical program. I worked with so many experts here at Phelps and within Northwell, and we also started recruitment efforts to bring in the best in the country. Over the next 2 years, we recruited Dr. Danila Silva, Dr. Yafel Cerule, Dr. David Gordon, and most recently, Dr. Ramadeep Sani, all very highly regarded physicians in their respective specialties. Together with nursing, physician, and our administrative leaders at Phelps, we've been successful in building that foundation and support for this program. And I'm thrilled to announce that within the next 10 days, we'll be putting shovels in the ground on the actual building of the Center for Advanced Procedures. I'll never forget that day when I saw that sparkle in their eyes, and that was the beginning of the story. I'd like to thank all of those in the community who are supporting this project and the others that are allowing us to provide expert care right here at Phelps. And now it is my pleasure to introduce you to Dr. Gottlock and our physician panel. I hope you enjoy.
Hi, everybody. Am I visible? Good. Thank you. Welcome, everybody. Thanks, Tracy, for that introduction, and thanks, Kevin and Jill. I'm Robin Gottlock. I'm a family medicine physician. I'm the medical director for our outpatient physicians in this area of Westchester, Rockland County, and Fairfield counties. And I have the pleasure of hosting this panel tonight with my esteemed colleagues. We're going to go through right now and do introductions so you know who everybody is here. So to start out, let's have Dr. David Gordon introduce himself.
Hi, thanks, Robbins. My name is David Gordon. I'm the Chief of Neurosurgery at Phelps, and my partner's Danilo Silva, who you see in front of you, Yafel Cerulli, who's working right now, and I manage the neurosurgery service at Phelps. I also oversee the neurosurgery service at Northern Westchester Hospital.
Thank you, Dr. Gordon. And next, Dr. Barry Geller.
Hi, thank you, Robbins. I'm Barry Geller. I'm an emergency medicine physician. I am the Associate Medical Director here at Phelps, as well as the Chair of Emergency Medicine.
Thank you. And Dr. Ramandeep Sani.
Thank you, Robbins. Good evening, everyone. I am the newest addition here at Phelps. I stepped into the role as stroke director as well as the director of neurology, and really happy to be part of this team.
Thank you. And Dr. Danilo Silva.
Hello, everybody. Thank you for being here. My name is Danilo Silva. I'm the site director here for neurosurgery at Phelps Hospital. I'm specialized in brain tumors, and we are very delighted and enthusiastic about everything that's happening here. It is great times and great, amazing things are happening here.
Thank you.
Thank you.
Thank you. So we're going to start, during the course of tonight, we're going to be sharing some cases of what actual patients will experience here at Phelps based on this new technology we'll have in the Center for Advanced Procedures. Before we go into that, I want to really help you understand what the Center for Advanced Procedures is. We're going to be using words like biplanes. And to kick this off and help us understand this technology, I'm going to ask Dr. David Gordon to give us an overview of what this represents.
Sure. First of all, I mean, Tracy mentioned what this represents to us as a whole and to the community. I mean, this is a really exciting project that started before I arrived and is coming to fruition. And, you know, our champion from the beginning has been Tracy Firetag, and we're really grateful for the support of senior leadership, Eileen and Toby Bank, James McCullough, and the entire system, as well as the community, so that we can bring this care to the community right at Phelps. The question about what this represents, it really is our ability to treat the most complex cerebrovascular disease at Phelps. The major part of that, of course, is the caregivers, the personnel, the nursing staff, the infrastructure. You know, we're the mechanics, Danilo and me and Yafel. But the function of the center and the core of the center is the BiPlane Angiography suite. And angiography really refers to the ability to image blood vessels. So, for example, cardiologists use angiography to look at the blood vessels of the heart. We use angiography to look at the blood vessels of the nervous system, the brain and the spinal cord. Biplane is exactly that. It's two planes simultaneously where we're able to image the blood vessels and then create three-dimensional reconstructions. It's the state of the art in terms of being able to diagnose and then perform minimally invasive procedures to treat the most complex cerebrovascular disease processes.
Terrific. Thanks for that overview. So we're going to be talking about how we're going to use this technology to help patients in our community, to help you, to help us. All of us will be patients someday, unfortunately, and we want to have this available to help us. So the first thing we're going to talk about is stroke. We hear about stroke all the time. You may or may not know what it is. It's an interruption of the blood supply to the brain. And if a part of the brain doesn't get blood or its nourishment, then that tissue dies. And depending on where that tissue is, it can have grave impacts for our ability to function with our body. So the first case we're going to talk about is a stroke case. So we're going to start with a patient. Now, I'm changing patients' names, of course, for their privacy. But these are real cases that have happened just not the real names. And I want this to be interactive. So I'm going to be calling on the doctors. I want to take us through this. And also for the audience, if you have questions, please type them into the Q&A and we'll work those in. I want to make sure everybody understands what we're talking about. So this first case is Mr. Smith. He's a 79-year-old man. He's a retired investment banker, lives up here in Westchester, enjoying his retirement. But one day he wakes up in the morning and he is starting to feel some right-sided weakness. He's kind of stumbling. He doesn't know what's going on. And he calls out to his wife and he's really not making sense. He's garbling his speech a little bit. Well, his wife is a smart woman. She's astute. She knows something's wrong. So she thinks it may be a stroke. She immediately calls 911. The ambulance shows up and they whisk her over to Phelps Hospital, knowing that it's a stroke center. So they arrive at Phelps Hospital and the first person they're going to meet there is Dr. Geller. Dr. Geller, can you tell us what you're going to do for Mr. Smith in this moment?
Sure, I will. I want to just take a step back. Even before the patient arrives, we start setting up for that patient. So we receive a phone call in the emergency room and we start mobilizing our team. The first thing that happens is that we identify a nurse and a physician who's going to be taking care of that patient. We also make sure that there is a room available for that patient, and we contact our radiology department, our CAT scanner, which is right there in the ER, to make sure that there's nobody on the CAT scanner. Now that we've set the stage for our expeditious treatment of this patient, we then meet the patient at the door and we do a brief history and physical. And as soon as we establish that there is in fact a stroke going on, we call it code stroke. In addition to the history and physical, we make sure that we do a finger stick. And the reason for doing that is to make sure that we're not dealing with one of the many stroke mimics, entities that can appear to be a stroke but are not. As we are making sure that in fact we're dealing with a stroke, we wheel the patient straight into the CAT scanner while they're still on the stretcher. And even as we transfer the patient from the stretcher to the CAT scanner, we don't want to waste any precious seconds. So we have a board on the CAT scanner which weighs the patient. While this is all going on, this gives a couple moments for the neurology team to arrive. And as they arrive, they start participating in the patient's care.
So Barry, Dr. Geller, what did you find when you examined this patient?
So as you described, the patient has slurred speech. They also had right-sided weakness. And those are both findings that are consistent with a stroke. We're not sure what type of stroke. And as the program develops, we'll be discussing a few different types of strokes. And our clinical suspicion for a stroke is high enough that we've already activated the code stroke. And when we did that, we've mobilized not only teams in the ER, but also teams in the rest of the hospital. For example, our laboratory is now clearing the space to make sure that any blood tests, any blood vials they receive from us, they'll be able to run immediately. The neurology team is being assembled and they're aware. And the neuro interventional team is also aware that there's a possible patient in the ER that they'll be taking care of shortly.
Thank you. So great, that's where this code stroke is called, and Dr. Sani's on call. She's at the hospital, and Mr. Smith is there. His wife is concerned. He's worried. Tell us what you're going to do for Mr. Smith, Dr. Sani.
So once the stroke code is called, as Dr. Geller alluded, many people are alerted that we have an acute stroke patient in-house. The ED, by that one activation, radiology is making preparations to get that CT done. My team is coming down in seconds to evaluate this patient, because we know from our literature, every single minute counts. In 1 minute, you could lose 2 million neurons. So our job is to make sure, are you having a stroke? What type of stroke are you having? Are your symptoms severe enough that this will leave you disabled? And what therapies can we offer you, depending on the type of stroke we identify with the imaging that's done in the ER? I'd like to share with you a few slides, and I think this will show you what our treatment paradigm is for every stroke code. I hope you can see it all. So in every stroke center, we have these strict time targets because we're trying to salvage as much brain tissue and identify every single patient that might be eligible for these acute stroke therapies. The ER team is integral to this. They are the first people to recognize the stroke patient at their door. They're the first people to activate the stroke code that alerts everybody. We attempt to get a CAT scan in under 20 minutes of that patient arriving to our door. We get lab results in under 45 minutes of that patient arriving to our door. And after clinically evaluating the patient, looking at all this additional data that we have, we're able to determine, do we think this patient is eligible for the clot bus drug TPA, or are they possibly eligible for a thrombectomy, which Dr. Gordon's team would perform with the angiography suite. Getting back to our case at hand, this gentleman, the first step is doing the CAT scan of the head. With his acute symptoms, we can't tell you what stroke subtype he's suffering from. 87% of patients will have an ischemic stroke, which means there is a blood clot that's interrupting blood flow to the brain. And the remainder of patients may have a hemorrhagic stroke, which means a rupture of a blood vessel that leads to bleeding in the brain. The CAT scan is a very sensitive test in detecting blood. So when we see a CAT scan and we see no evidence of bleeding, that immediately tells us we're dealing with an ischemic stroke. There is a blood clot leading to these symptoms. The next question is, well, can we give him the clot bus drug? Or do you think, or can we proceed with angiography? This gentleman woke up with his symptoms, so we don't exactly know how long he's had these symptoms. And in order to get the clot bus drug, we have to know that the symptoms have only been present for about 4.5 hours. If we are unable to determine the onset of symptoms or the duration of symptoms, the patient cannot receive this medication. So then we proceed to our next option. Is there a large blood vessel blocked that we might be able to open with a catheter and proceed to the angiography suite? So our next study is CT perfusion. This is showing us how much injury do we have. And it's color-coded to make it very simple. What's pink is what we consider our core infarct. This is irreversible. And what's green is showing you all the tissue that we have the potential of losing because of a large artery blockage. As long as we have a small area of injury, but a large territory that's salvageable, we think that we can proceed with this procedure. The third imaging that we retrieve all of these images under 20 minutes of this patient being in our ER, is to see, is there a large artery blockage? We know that large artery blockage lead to the most severe stroke. We know that restoring blood flow, it gives us the best chance of a favorable outcome or minimizing the patient's deficits or possibly even resolving them completely. We also know when we have a large artery blockage like you see right here, you'll see that this is a mirror image. On your right-hand side, that's actually your left artery. And on your right-hand side, this is your left artery over here. You can trace out the artery right here. That's completely open and you can see the branches. But on the contralateral side, you can see that obviously there's an abrupt cutoff. There is a large artery blockage there. Now, the challenge is with large artery blockages, the clot bus drug is not enough. We know this from all of our research. It's just not enough. And that's why further research in angiography and clot extraction and recanalization of these vessels were done for the past 15, 20 years. And we've seen that if a patient is eligible for both of these treatments, that gives you the best chance of recanalization as well as good outcome. Also, we know that angiography alone and thrombectomy, which Dr. Gordon's team performs, if that's performed readily and we're able to open up that vessel, that also will lead to a good outcome. So in this patient, since we see a large artery blockage, he's not a candidate for the clot bus drug. We contacted our neurosurgical team to assist to see if they can proceed with angiography and thrombectomy. I'm going to stop sharing at this point because I think Dr. Gordon has some additional slides.
Actually, Ramandeep, do you have the pre and post thrombectomy slide?
Yes, I do. There you go.
So at this point, Dr. Sani, your team's going to reach out. You've realized this patient could benefit from an intervention, and you're going to be calling Dr. Gordon.
Exactly.
Great. Dr. Gordon, could you walk us through what you're going to do to save this person from this stroke?
So we, Ramadeep calls and we come running. This patient, as Ramadeep eloquently explained, was, it is a very good candidate for this procedure. It's a minimally invasive procedure. It's catheter based. It's performed in the angiography suite. On the left side of your screen is a picture of dye being injected into the left carotid artery. So we all have 4 major blood vessels that bring blood to our brain. This is the pulse that you feel in your neck. This is the left carotid artery, and it's like I'm looking at the patient's face. And the arrow is pointing towards the blockage, which is the large vessel occlusion that has been discussed. On the right side is a picture following the thrombectomy procedure, which I can show you a couple of devices in a second, what we use to perform this. But the idea is to rapidly but safely get to the area of blockage and use these intravascular devices, these catheter-based devices inside the bloodstream and the blood vessels, and remove the clot. And Ramadeep, if you want to stop sharing, I can try to share mine.
There you go.
Thank you. Give me 1 second. Okay, so just to give you a picture to go with the explanation, there's very rapid development in the endovascular research space right now. So what I mean by endovascular is inside the blood vessels or via catheter-based approaches. And what you see on your screen are examples of aspiration catheters. So these are catheters that are designed to navigate through the tortuosity of the natural tortuosity of our blood vessels and access the region of occlusion or blockage of the blood vessel. And then down in the bottom right-hand panel of the screen are 2 examples of, they're essentially vacuum cleaners. So these are devices that you turn on and they suck through the aspiration catheter. And the aspiration catheters themselves are often enough in the most rapid way to restore blood flow to the brain. We also have other devices. This is a cartoon that shows one example of these devices. The red is the carotid artery on the patient's right side, as if I'm looking at the patient's face. This is the aspiration catheter that I just showed you a few examples of. And then through this catheter, there's deployed a device called a stent retriever. So this represents the blood clot that's blocking the blood flow, like in our patient. And this stent retriever is deployed. It opens up into the blood vessel and into the clot. And as it opens up into the clot, it grabs the clot. And the combination of that stent retrieval device and pulling blood into the aspiration catheter often allows us to revascularize or open up the blood vessel and restore blood flow to the brain. So that's what happened here. And then we called Dr. Sani and said we were successful.
Awesome, great. So you just removed the clot. The blood is flowing through the brain again, saving that tissue. So Dr. Sani, what do we do now for Mr. Smith, and how's he doing?
So after we do these procedures, we monitor these patients very closely. They come to our ICU. We're checking on them every 15 minutes, every 30 minutes, every hour for the next 24 hours. And then we do follow-up imaging to see how they're doing, and we base a good outcome based on, have we seen improvement in the symptoms that brought the patient into the hospital? And then finally, are these patients able to walk out of the hospital, or do they need rehab? So, and we do some follow-up imaging, which I want to share with you, and I think that would illustrate it best, the impact of all the good work that our team did. Can you all see my slide?
Yes.
So what you see here on your left-hand side is this patient's MRI. And an MRI is basically showing you the damaged tissue. And if you remember the first screen where I showed you, well, we could see the damaged tissue in pink and we saw all that green tissue that was at risk, we were able to save nearly all of that. And what you see in white is the damage that was left. But what I'm happy to say is this patient had minimal symptoms. And the very day we discharged him, we were able to discharge him so he could attend his grandson's bar mitzvah. He has since followed up with us in the office and he has no neurologic deficits at all. This is a favorable outcome. This is what this team works hard to do. This is what makes us want to do another case and another case.
So that's remarkable. So Phelps right now has that technology to go in and to remove those clots from the brain and save these patients. So a great place to come if somebody in our community needs help with their stroke. We can really do this life-saving treatment. So we've talked about strokes, and that's one of the main things we're going to be able to treat in this Center for Advanced Procedures. Another diagnosis we want to talk about is brain tumors. I think all of us worry sometimes that we have a brain tumor, or maybe it's just me, but I'll forget something, I'll drop something, I have a headache, I'm sure I have a brain tumor. Unfortunately, some people will develop those, and Phelps has the ability to treat those patients. So we want to talk about another patient who also has been treated. And again, I'm changing the name, but this is a patient who had a tumor. So let's go through the process of what this patient would expect. So this patient is Mrs. Katz, and she's a 70-year-old former advertising executive. And for the last few weeks, she's been getting these progressive headaches, a little bit of gait imbalance, and some short-term memory problems that she's never really had before. And her family's a little bit worried. It's advancing a little bit quicker. So they think, let's take her to the emergency room. Let's see what's going on. And so they drive her themselves and bring her to Phelps and just put in a wheelchair and brought him to the emergency room. Dr. Geller, could you tell us what your team would do for Mrs. Katz when she first comes into the emergency room?
This is Mrs. Katz is a 70-year-old female. She's brought to the ER by her family. She's brought into a room in the ER, and the physician would come and start eliciting a history to figure out why she's here. So she tells us that over the last few weeks, she's been having this progressively worsening headache. In addition to that, she describes that her walking and her balance are a bit more clumsy than what she's ever had. And in addition to that, she's also noticed that her short-term memory is also progressively getting worse. So, you know, I as a physician would be, you know, pretty concerned about what's going on. And we would start ordering some tests and also perform a physical exam. So an IV would be placed in her and blood tests are sent. And the physical exam reveals that her blood pressure is mildly elevated. She doesn't look in any type of acute distress. However, when we go through a thorough neurological exam, we find out that the right side is weaker than the left, and the right arm is actually not as weak as the leg. So the leg is weaker. And the fact that she has the complaints that she describes, and the fact that the physical findings are abnormal, it makes us order a CAT scan of the head. So we're ordering a CAT scan of the head, and we see that the results are abnormal, and the results show a tumor. And once we see a tumor, we would consult neurosurgery.
All right, that is Dr. Silva's cue. So paging Dr. Silva to the emergency department. Dr. Silva, what's your role in this process?
As Dr. Gordon.
Hey, I'm I'm going to share this. I'm going to share the screen. They called Dr. Silva and the CT led to an MRI. So let me.
Exactly. As Dr. Gordon said, as soon as we get the text and the call from Ramandeep Sani, Barry Geller, we go running. We get there and we do a thorough and focused neurological exam. But most importantly, we go and we discuss the imaging findings with the family. And unfortunately, in this case, this is the MRI of the patient. And we see that we have a large mass, which is white. The mass is basically this white tumor that we are seeing in this MRI. It is, in terms of brain tumor, if we could classify this one as a small, medium, or large, this would be a very large brain tumor. Okay, and that's why she was developing these symptoms of memory problems, difficulty walking, balance problems, and also weakness on the other side of her brain, on the right side. And this is a very critical clinical scenario, requires a multi-specialty team to take care of this patient. And thank God we have the best clinical team at Phelps. We have amazing doctors, amazing physician assistants, but most importantly, we have the best nurses in the world. That I have, I'm completely sure about that. And this patient is placed in the ICU, and we talk about the plan of care with the patient, with the family members, and we usually make this decision together as we discuss the natural history of the problem and the options for treatment, right? And when you have a tumor that it's bigger than a baseball in your head, which is basically the situation here, the main part of this treatment is to do surgery. We have been doing constantly and routinely brain tumor surgery at Phelps now over the last 2-3 years. We're basically doing tumor surgery every week, at least 1 or 2 cases. And as part of the treatment plan to remove a tumor like this, it is very important that we first stop the blood supply to the tumor. And the most important technology that we need in order to do that is to have a BiPlane suite. So our endovascular and catheter-based colleagues who know this technique can go there with a catheter and stop the blood supply to this tumor, which facilitates the surgery and actually makes the surgery much safer. A patient with a tumor like this can lose 2 liters of blood during surgery. And with this technology and this availability that we're going to have at Phelps now, this surgery can change from, instead of 2 liters, the patient will lose like 200 cc's or so. It is a much safer, and we are able to achieve a complete tumor resection much more often after we do this procedure called tumor embolization, which is essentially stopping the blood supply to the tumor. And we will have these here at Phelps, close to all of us. This is not something that is only available in Manhattan anymore, in the city. We're going to be doing this here close to us, close to you.
All right, so you've talked to the patient, you've told them the unfortunate news they have a tumor, but you're giving the good news that we have treatments for it. And the first thing we're going to do before we cut open their head and remove the tumor, we're going to starve it to death. And that's where you're going to work with your colleague. And we're going to bring Dr. Gordon back into this conversation, who's going to talk about how he is going to go in endovascularly and kill this tumor, shrink it down.
So, Danilo mentioned the idea of a multidisciplinary team, and that couldn't be said any better. So our conversation with the family occurs with multiple practitioners that are viewing the patient in their clinical scenario from kind of different perspectives. This is a live angiographic image that I'm going to play here. This is blood flow in the form of dye, showing that in live real time, filling this blush, and this represents the tumor that you saw in the MRI. So this picture is as if I'm looking at the patient's, Mrs. Katz's face. Her left eye would be here, her right eye would be here. This is where the brain is. And this blush is very characteristic for a kind of tumor called meningioma, which is usually a benign tumor of the coverings of the brain. So we're able to place catheters using live fluoroscopy or the angiography suite into the blood vessels that subserve and supply the tumor. And if it's deep, this is a view because what we want is biplane or two planes of attack where we can visualize where the tumor is. So this outline here is a microcatheter that's in a very small blood vessel that lies on the membrane that overlies the brain. And this blood vessel, the middle meningeal artery, is supplying this tumor. All of that vascular blush that you saw filling is tumor. This is all tumor vessels. So this is a very vascular tumor, as Danilo was talking about. So we have various devices and various materials that we use to safely block off the blood supply to these tumors. And once the blood supply is blocked, this is the same exact catheter in the same exact place that shows a normal filling of normal blood vessels on the coverings of the brain and no filling of the tumor. So once we've accomplished this, Danilo is usually down in the room watching. We're complete with the procedure. This is a CAT scan following the procedure. And I just wanted to show this because, so bone is white on a CAT scan. And this is a picture of somebody's, of Mrs. Katz's brain where we're taking slices like this and looking up at it. So this is the left side and this is the right side. This is the front of the head. This is the back of the head. This white is bone, but this is also very bright here. And that represents the particles that we use that are nanometers in size that we injected through our microcatheter into the tumor. And this shows that the particles penetrated the tumor because they light up with the contrast that we use to inject them. So then it's back to Danilo to do his magic.
How long do you wait between doing this embolization and then doing the surgery?
So that's an excellent question. In general, we try to wait 2 to 3 days after the procedure. And the reason for that is we're essentially, I mean, we were talking about stroke before, where the blockage of blood flow to the brain results in the brain starting to die. We're creating a stroke in the tumor by blocking its blood supply. As the tumor starts to die, it also starts to soften. So not only is there less blood supply to the tumor and there's less blood in the tumor consistency becomes soft so that it becomes safer, more expeditious to remove so that we can effect, as Danilo said, a more maximal resection in a safer manner. So we try to wait between 2 and 3 days. We don't want to wait longer because swelling could occur as a result of this process, and that could contribute to somebody's neurological problems.
Interesting. Great. All right. And then Dr. Silva, you're back. You're going to do the surgery. Tell us briefly about what happens and the outcome for Mrs. Katz.
So very good. So we take her to the OR 3 days after the procedure, after we cause the stroke in the tumor, right? Now it's the good stroke. We're devascularizing, removing the blood supply from the tumor. We go to the OR, we use these navigation and devices, which is a computerized system that we have available at Phelps 24/7 now. And it really allows us to open the skull exactly where the tumor is and provides us with a very safe access to the brain tumor. We're able to remove this tumor entirely. It took us something in the range of 6 to 8 hours, I remember very well. The resection was very good. The patient did amazing. And most importantly, the care of this type of neurological patients, the care doesn't stop after surgery. There is a very important part of the care that happens during the rehabilitation process. Somebody who has a brain surgery for 8 hours, most likely will need some sort of rehabilitation after the surgery. And at Phelps, we have a very, very good, amazing team of rehabilitation medical professionals, physical therapists, and it is an inpatient acute rehab service. And it is really good. We can go there and see our patients during the time that they're still doing rehabilitation process. This is a very unique feature that Phelps has. We are able to monitor and follow up on our patients and during the time that they are actively getting their rehab. This is very unique to our scenario, and then patient did well. We were very happy to change the natural history of this problem for her.
Awesome. So that's great. So now we've talked about a stroke that we could treat. We've talked about a brain tumor that we can treat. We want to present one more case. We're getting short for time, panelists, so we'll go through this case rather quickly, but I want to illustrate the capabilities we have for one more thing, and that's an aneurysm. And you may have all heard of aneurysms. And this is near and dear to my heart. My one-year-old son had my son had an aneurysm when he's 1 year old. And it's dramatic, it's scary, but there are great treatments for it. He's doing very well, thank you. So we're going to be talking, though, about someone younger. These things happen, ruptured aneurysms in younger patients. We're going to talk about Mrs. Brown. She's only 45 compared to these other patients in their 70s. And she is a school teacher. One day on a weekend, she suddenly had the worst headache of her life, suddenly. Her family was very worried about it. Her husband called 911 and she was brought into Phelps emergency room. Barry, can you tell us, Dr. Geller, what happened to Mrs. Brown in the emergency room?
Yeah, certainly. So this 45-year-old female comes to the ER and it's a very dramatic presentation. It's the type of patient that you really never forget. She's very uncomfortable appearing. She complains about the worst headache of her life, a thunderclap headache. And in addition to that, on physical exam, we note that her blood pressure is elevated, that the light is bothering her eyes, and that her neck is quite stiff. Once we establish that, we call a code stroke in order to get the support of our colleagues, both the neurologists and the neurosurgeons. And then we rush the patient to the CAT scan to see what's going on. Once the CAT scan is done, at this point, the neurology team has already arrived and they start participating in the patient's care.
Dr. Sani, page to the ED. Tell us what you're going to be doing for this patient, for Mrs. Brown.
So we come running and, our ED team fills us in on why they activated the stroke code. We quickly evaluate this patient. And the key in this case is really the CAT scan. If you recall, I told you that 87% of the strokes are due to a blood clot. A small fraction are due to a bleeding vessel. This is that patient. And even though these represent a fewer number of stroke cases, this is the most dangerous type of stroke. So the CAT scan is the key here because that's going to tell me, is there any bleeding that fits with her symptoms? And that's what we look for.
I could show you the CAT scan if you'd like.
Thank you.
That would be great.
That's not the CAT scan.
Please don't make that the CAT scan.
Oh, okay. There's the CAT scan.
Yeah. So as you can see that her brain is bathing in blood. What you see in white that's surrounding every part of her brain is blood. And now the next step is, where did that blood come from? It had to have come from a blood vessel. Which one? And that's when we call our neurosurgery team, because the most important thing right now is to stop that bleeding.
So, sorry, go ahead, Robbins.
No, I was going to say neurosurgery. Let's hear from you, Dr. Gordon.
Okay. These are some adjunctive studies that we get on all patients who have a suspected aneurysm. This is just a representative slice, again, through the brain like this, where the images are acquired after an intravenous injection of contrast. And this shows that there's an aneurysm on this vessel. These images can be reconstructed in 3 dimensions and provide real 3-dimensional characteristics of the vasculature itself and the morphology of the aneurysm. So this aneurysm here is small, but we have an understanding of its irregularity, its size, exactly where it's located. The patient then is, so the biggest risk to this patient, this particular patient, and most patients with ruptured aneurysms that arrive at the hospital is the risk of rebleeding. An aneurysm is like a little blister as you saw, or a balloon on a blood vessel, and it's ruptured, it's bled, it has stopped bleeding at this point. The pressure inside the head has caused the bleeding to stop, but we know that that aneurysm is weak and that the risk of re-hemorrhage within the first 24 hours, 48 hours, and 2 weeks is very high. So by our practice standards, we treat every aneurysm that has ruptured within 24 hours of presentation. And the way that we can treat these aneurysms, the majority of these aneurysms now are treated via catheter-based techniques in the BiPlane Angiography suite. This is why we're very excited about the Center for Advanced Procedures. So these are just pictures of some coils that we use. So this is one of the devices that we can deploy into the aneurysm itself. And we do this by, in high magnification, navigating small micro catheters through the vasculature into the aneurysm itself. And these coils, these small metal coils, are very soft and they don't have memory. So the biggest advance in coil technology is that the coils now take the shape of the aneurysm itself. So there are certain measurements that we use in order to choose the sizes of the coils that we use and the types of coils that we use. But we use coils when we think it could be safe and feasible to treat the aneurysm completely and occlude it or block it from the circulation so that the risk of re-hemorrhage is mitigated as much as possible. This is a three-dimensional reconstruction of a catheter-based angiogram in the interventional or angiography suite. And this shows a very large aneurysm. And on these three-dimensional reconstructions, we have a picture of a little person, and that gives us our orientation in terms of which direction we are viewing the blood vessels. And this is the carotid artery once again, and normal branches, and this is the aneurysm itself. So I know we're running short on time, but I did want to show a live video of what we call balloon assisted coiling or balloon remodeling. In the background, you can see the patient's skull. So this is an unsubtracted image. In BiPlane angiography, we generally work with subtracted images so that we remove bone and we remove metal from the fluoroscopy or live X-ray so that we can then navigate through roadmaps that we create and keep the patient safe while we're treating the aneurysm. So just to orient you, we're looking at the patient from the side of the head. This is one catheter that has a balloon within the catheter that has been inflated with contrast so we can see it, that is blocking the neck of the aneurysm. There's another catheter here that is inside the aneurysm, and we watched it fill with coils. The balloon protects the coils from protruding into the parent vessel or the blood vessel that the aneurysm arose from so that we avoid complications such as stroke. I want to go back and just show you, I briefly did already, what an aneurysm looks like. So in the less than 20% of patients in which endovascular or catheter-based procedures will not be safe or effective in treating their aneurysm, we operate. And so Dr. Silva and I do open vascular neurosurgery. This is a very magnified picture of a patient's brain. The patient's head is tilted back and to the right. The skull has been removed, a small window of bone in order to access the membrane surrounding the brain, which has been incised and reflected forward. This is a cotton patty that's protecting the frontal lobe of the patient's brain. And this is the temporal lobe here on the left side of your screen. And this is obviously the aneurysm, but I like showing this video because you can see the blood swirling inside the aneurysm. And it just represents, I think, dramatically why these are very dangerous lesions or pathologic problems for patients that we need to treat.
Wow, thanks, Dr. Gordon. Amazing images. That's just remarkable what can be done. So just to wrap up, Dr. Sani, you're going to be seeing this patient. How did Ms. Katz do after getting these procedures done?
So that was the first step.
Sorry,
stopping
Mrs.
the
Brown.
bleeding. Sorry, that was the first step, was to stop the bleeding. That was the most important step. And David's team was able to find that aneurysm, secure that aneurysm. But if you recall the CAT scan, there was a lot of bleeding surrounding her brain. The brain does not like blood. Blood causes a lot of inflammation. Because of that, there can be a lot of complications. So we have to watch Mrs. Brown in our ICU. We have a wonderful critical care team, in particular neurocritical care team, that watches this patient really closely for all these complications that we know that can happen with this type of stroke. You know, the other blood vessels can get irritated and get blocked off. She can start to form little clots because of all the inflammation that the blood is causing. She can go into heart failure. So she has to be watched very closely for the next 7 to 10 days. And once we get out of that, then we can say we're finally out of the woods. And she'll likely need some physical therapy. And when she comes back to follow up with us, you know, we try to educate her about her stroke risk. We make sure that she shares this information with her family, because we know that aneurysms do run in family members. We want to make sure that, you know, we can prevent the next rupture.
Thank you so much. We're at the end of our time, panelists. It's been fascinating to hear about what we can do at the Center for Advanced Procedures, strokes, brain tumors, aneurysms. Thanks for illustrating this for us tonight. I appreciate your time with us. I'm going to turn it back over to Jill Sibilia.
Good evening, everyone. I just really want to thank you so much for joining us. And I want to thank Dr. Gottlock and all of our panelists. I really think we have a dream team here at Phelps and our physicians. And they also talked about the collaboration, not only that they have with each other, but with all of our physician assistants and nurses and excellent team. And I just really want to highlight that. It really is quite, I think, comforting and reassuring that, that we'll be in such great hands if we come to Phelps. So I'm Jill Sibilia. I'm the Vice President of Development here at Phelps. And again, I want to thank you for joining us. All of the projects that you've heard about tonight, earlier in the video, and the Center for Advanced Procedures are made possible thanks to capital investment from Northwell and from the generous philanthropic support of people like you who are supporting these projects and also supporting the people who make the projects possible. So I want to thank you again so much for the support and for joining us this evening. And now it's my pleasure to turn it over to Eileen Egan, who will close tonight's program.
Okay, that's better. Jill, thank you so much. An amazing presentation. Thank you to our expert panel, Dr. Geller, Silva, Gordon, and Dr. Sani. I listened to the case studies and the debriefs, and it's amazing that dedication and the compassion that comes through when you talk about patients and the way you care for them. It truly is, like you said, Jill, the dream team. Thank you to Kevin Plunkett, our board chair, for being so involved. Our moderator, Dr. Gottlock, who's got many talents. We're seeing them every day. It was a great story for the introduction that Tracy gave us, and to see that vision and to act on it. Thank you to Tracy. And last but not least, thank you, Jill. This would not have happened without her. This was her. This was an idea that she had, this concept of bringing what we're doing here at the hospital to the community and inviting everybody to see the amazing and the details and the amazing things that we're doing. So thank you, Jill, for making this public to our community and letting them know that Phelps is the place to be. We have this fabulous neuro team that can handle anything. So like you said, you don't have to go to the city for tertiary care. You can have it right here at Phelps. I'm so proud to be here. So thank you all. Good night to everybody that attended and participated, and we'll see you at the next Insider Series.
Good night, everybody.
Good night, everybody. Bye-bye.